Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
All right, welcome back to Cardiovascular Matters. You know, the premise of this podcast was to give patients and loved ones more time with the physician. And we're so lucky to have Dr. Craig Walker, who's one of the world's greatest cardiologists, and he's also a great friend of mine. But he has been in practice for 40 years, and I've watched his practice evolve. And, what we're going to be touching on today is obesity. And, he treats the entire patient. If they come in with cardiovascular problems, he gets back to the root cause of what may be causing some of these issues. And one of the biggest things he has faced with his patient population is obesity. And I think you're going to enjoy these next few segments we have because it's such a big thing. And there's great medications available now. And, the hurdles to get this stuff treated are no longer so great. It's not like you're looking at a big surgery or something that's irreversible or risky. I mean, this stuff is safe. So stay tuned. Take a listen to these next few segments, and we hope you get something out of it. We've spent the last two sessions talking about the epidemic of obesity, its impact on everyone's health. And we've also talked about some of the medications that are available now that are making huge impacts on people's lives. And today, we're going to take that one step further. Dr. Walker?
Yeah, Terry, we talked about one diabetic medication that has really been shown to help with weight loss. There's another. And this medicine was started for diabetes, but it's being used now much more so in non-diabetic patients and even diabetic patients. It does help control blood sugar in a different way, this class of drugs do. But this class of drugs does other things as well. For instance, in diabetic patients, we know that kidney failure is often a problem. And in fact, most people that have to take chronic dialysis were people who had diabetes before. And certainly being able to avoid that is a big deal. I don't think any of us relish the idea of going in 3 times a week for hemodialysis or every day doing peritoneal dialysis at home. It really ties one down. But these medicines have been shown to A, help control diabetes, B, lessen the likelihood of going on to kidney failure, C, this class of medicines has been shown to be one of the most effective therapies that we have for congestive heart failure. That's one of the biggest heart problems that exists in our country and throughout the world. And it's a tremendous cause of death and disability, and it's profoundly expensive to the healthcare system. This drug has shown great benefit in that problem. And then finally, this drug has been associated, once again, with significant weight loss. Now, this works in a completely different way than the GLP-1 agonists. These drugs are collectively called SGLT2 inhibitors. And the one that I've used the most is empagliflozin, which is known as Jardiance, but there are many drugs that fit within this category. Now, the way that these medications work is they block the reabsorption of glucose in the proximal convoluted tubule of the kidney. So as blood goes out to our kidney to get filtered, typically we have things that are reabsorbed, blood sugar being one of those, sodium being one of those. Well, sodium glucose transport inhibition, big words, big medical words that I think are created to confuse people, but this one's pretty simple to understand. It blocks the reabsorption of sugar. And so we pee out the glucose. That's simple.
Okay.
Now, as we pee out the glucose, it does have a bit of a diuretic effect, but it also It also has a caloric wasting effect because there's a lot of calories in the sugar that's being peed out. And so our body simply is getting rid of those. Now, what was shown was that this really helps to control diabetes. The drug was developed as a diabetic medicine, but this drug had this massive impact in heart failure. Now, we typically classify heart failure in two ways. We have heart failure where the contraction of the heart is diminished, and we call that reduced ejection fraction heart failure. But we also have heart failure where the heart is just stiff. It can still contract pretty well, but it's stiff and it does not contract as well. And we call that preserved ejection fraction heart failure. Well, SGLT2 inhibitors are the first class of drugs to show level 1 evidence in preserved ejection fraction heart failure. This is very important because preserved ejection fraction heart failure, contrary to what many people think, has a really bad prognosis. It's almost as bad as the prognosis of a diminished ejection fraction or weak heart failure. And being able to treat this is important. Well, we have several drugs that are pillars of therapy for reduced ejection fraction heart failure. There are 4 classes of drugs, and they're pretty effective. And new data is showing that we should put patients on all 4 of those classes of drugs. One of those drugs are the SGLT2 inhibitors. And these drugs, the initial starting dose is the same as the final dose, so you don't titrate it. These drugs have shown reduced mortality, reduced episodes of heart failure. They've been pretty incredible. On top of that, these drugs have been shown to lessen the likelihood of going on to develop kidney failure over time. Now, as a diabetic comes in, historically, doctors have focused on controlling the blood sugar, and that's important. It's important to control it to stop one from getting diabetic ketoacidosis. But it really kills diabetics over time, or heart attacks, strokes, kidney failure, and I think we do far too little to protect against those issues. And certainly the societies are recognizing that as well. So now the American College of Cardiology, the European Society of Cardiology, the American Diabetic Association are looking at patients who have diabetes and insulin resistance and suggesting that one of the pillars of therapy early on in these that we should consider SGLT2 inhibitors. We should consider GLP-1 agonists, and that these could improve the prognosis in these problems. Now, when a diabetic patient comes in, one of the things I like to always do is check a urine on them, not just to look for sugar, not even just to look for protein, but to look to see what is the albumin to creatinine ratio. If we have an elevated albumin to creatinine ratio greater than 30, then that patient's at higher risk of going on in the future to developing kidney failure. The sooner we find that, the sooner we can start medicines to decrease that risk. And so one of those medicines are the class of drugs we call SGLT2 inhibitors, the diabetic medicines which help us lose weight as well. But another class of drugs has recently come out called a drug called finerenone. Whenever we see this high albumin to creatinine ratio in the urine, we know that this inflammation going on in the kidney, that inflammation is integral in destroying the kidney. And so if we can intervene and stop that inflammation from occurring, we may prevent the problem of kidney failure or certainly delay it tremendously, which is very important. We know that if we have a diabetic patient lose weight, their diabetic control is going to be better. So this class of drugs we call SGLT2 inhibitors, even in non-diabetic patients, they're more glucose normalizers, I would describe them, than they are drugs that just profoundly drop your blood sugar. In fact, in diabetics, when they take these medicines, and right now many non-diabetics are on this for heart failure, they're on this for weight loss, or they're on this for protection of the kidneys. But in non-diabetics, it almost never lowers blood sugar at all. Its major thing is in preventing these other issues. In diabetics, it lowers blood sugar somewhat, but again, it is not the strongest diabetic medicine. These drugs, even though they were developed for diabetes and their first approval was for diabetes, they are now used more to prevent these other problems. So it was first approved for diabetic control. Then later on, it gained approval for heart failure treatment with reduced ejection fraction. Subsequently, it gained approval for heart failure with preserved ejection fraction, and now it is the only drug that's considered baseline therapy for people who've had episodes of preserved ejection fraction heart failure, where the heart by echocardiogram is contracting well, but it's not relaxing well, it's not filling well, and because of that, fluid backs up and people get short of breath, and that is associated with increased risks of death. And recently, the most recent approval of this drug is to prevent kidney failure in people with type 2 diabetes and other problems. Now, because this drug causes one to lose sugar in the urine, it causes weight loss as well. But I think there are precautions that we have to consider. Okay, when we use this drug, and if one has a lot of loss of sugar in the urine, and if someone is incontinent, that can be a problem. And the reason it can be a problem is because you have sugar in the urine and you have a perfect culture medium for yeast, you have a perfect culture medium for bacterial infection. And so in taking these are things that are very important. One must keep themselves well hydrated. One should practice very good perineal hygiene, or should make sure that they're not wet in their private areas for any length of time. And in fact, when I see a patient and I'm considering this is a conversation that I have up front. This medicine is miraculously helpful medicine in many people, but it is crucial. It is crucial to maintain excellent perineal hygiene.
Interesting. Dr. Walker, tell me more about this kidney failure within diabetic patients. I mean, this is a dreaded addition to an already tough disease to manage.
It is, Jerry. And you know what's happened is with the SGLT2 inhibitors, when one first starts them, because they cause a bit of more urine loss than you have before, right at first sometimes kidney function will look like it's going to get worse in the first week or two. So if you look at the measures that we look at, the blood parameters, creatinine and BUN, they often look a little worse initially. But then that stabilizes. And then what happens is the rate of decline of kidney function falls. And so, especially if we can put people at younger ages and earlier in the stages of diabetes on these medicines, then we stabilize the kidney function and it stays at very normal levels. Now, Terry, there's so many things that people don't understand. People look at what we call glomerular filtration rate and they say, well, if it's 60, we consider that normal. It's not necessarily normal. And in diabetics at that point, they may already be spilling a lot of urine. So we have to be more careful with diabetics than we've historically been. Checking the urine albumin to creatinine ratio is crucial. And if we check that early, and if we start the appropriate medications, SGLT2 inhibitors, or in certain cases, mineralocorticoid receptor antagonists, drugs like finerenone, we can absolutely lessen that risk of going on to kidney failure. And people with type 2 diabetes have a 2 times higher risk of a stroke than people without diabetes. Every 2 minutes, an adult with type 2 diabetes is hospitalized for stroke. Stroke in people with type 2 diabetes is associated with increased risk of subsequent strokes, greater functional disability, longer in-hospital stays, and increased likelihood of death. And, I can't caution diabetics enough about this. Take diabetes seriously. It is a big problem. Realize it's associated with much higher rates of cardiovascular problems, hence the reason I became so interested in this. Understand that losing weight with diabetes is part of the treatment. and understand that now we have medicines which allow us to achieve this in almost everyone. Most of these medicines are very well tolerated, albeit they can have some initial side effects. We can typically mitigate those side effects with certain practices that occur, but I think this has really revolutionized the way I treat so many of my patients. Now, I mentioned this drug has been shown to be the SGLT2 inhibitors very, very important in terms of improving survival. There was a difference at day 7, by day 7 in survival, when started on these drugs earlier with heart failure. That was starting to become statistic. Out by a couple weeks, it was quite significant. So this is very impressive drugs. These work effectively, they work quickly, and I think, once again, these are drugs which are revolutionizing how we treat patients who have diabetes, and particularly diabetics who are overweight.
That is a very, very thorough and informative wrap up to this segment. I really appreciate you sharing your knowledge with us, and really how your practice has evolved over the years as not just treating the cardiovascular patient, but treating all these issues, especially obesity, as it pertains to just wellness. Thank you so much, Dr. Walker. Thank you for joining us here at Cardiovascular Matters. We've just completed a couple presentations on obesity and some of the great new drugs and treatments that are incredibly impactful. I'm living proof. I'm in a plan right now, and I was motivated by Dr. Walker to do so, and it's changing my life. So if you're a patient out there and you've tried everything else and you just can't get the weight off, look into this. I mean, he's easy to reach at www.cardio.com. Everybody have a great week, and thanks for listening.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.